To help you understand what is happening between the time of your operation and getting the results, we would like to demonstrate what happens to the specimen after it is removed from your breast. We were advised by our patient focus groups that patients may not wish to see anything that would make them squeamish, so instead of using breast tissue, we've chosen to use a cake. In this example, we are demonstrating what happens when we take just part of the breast away, breast conservation surgery or a wide local excision. A mastectomy could be imagined in terms of the whole cake being examined, and a similar process would be carried out in the lab. So here we have a cake which has been baked with a walnut in it. We are using the cake to represent normal breast tissue and the walnut to represent the breast cancer, and the icing represents the skin over the breast. The aim is to cut a cylinder of cake with the walnut in the centre without the walnut touching the edges of the piece of cake removed. The walnut needs to be completely surrounded by a margin of cake. This is exactly what we are trying to do when we do a wide local excision of a breast cancer. We need to remove the cancer with normal breast tissue all the way round so that the cancer is completely removed without it touching the edges of the specimen. In theatre, the specimen is marked with silk sutures to show which way round it was when it was within your breast. We mark the specimen to show which part was facing the top of your breast, which part was facing the outer side of the breast, which part was closest to the nipple with different lengths of sutures, and then we apply metal clips which will show up on the X-ray. We often X-ray the specimen to try and check that the cancer is in the middle of the specimen at the time of your surgery. Even so, we cannot be certain exactly how close the cancer comes to the edge by looking or feeling it during the operation or by using an X-ray. This is because the cancer cells may go further into the tissue than anything we can see or feel at the time of your operation. The only way the true extent of the disease can be accurately determined is by the specimen being examined under a microscope after the operation. This is called histological examination. If the X-ray shows that the cancer comes quite close to one edge of the specimen, then we will remove a little bit more from your breast during the same operation. After your operation, the specimen is usually put into a pot of formaldehyde solution, which slowly penetrates the tissue over at least 2 days and hardens and protects the specimen. It is taken to the pathology lab so that it can be processed and looked at in detail under the microscope. This is how we find out more about the tumour and how we know whether the lesion has been removed with enough normal tissue around it. In the lab, the pathologist checks the patient's details on the form that accompanied the specimen. First of all, the specimen is painted with different colours of ink. Each side of the specimen is painted with a different colour, so that the pathologist can identify which area of the breast is being looked at after it is sliced up, and so the pathologist can see where the original edge of the specimen is. This specimen is painted with green, blue and black ink. It isn't easy to see the different colours with the naked eye, but the colours will be visible under the microscope. The specimen is initially sliced into thick slices by hand. At this stage, it is sometimes possible to see how close the cancer comes to the edge, and this can be measured with a ruler. These slices are put into cassettes for processing, where the specimen is dehydrated to allow wax to be added. These dehydrated slices are embedded in wax to make them more solid and to allow for much thinner slices to be taken. A sample of these thin slices are applied to glass slides. At this point, the slides are still transparent, so stains are applied to make the cells show up so that the pathologist can see them under the microscope. The finished slide shows the tissue stained pink and the ink visible at the edge. The pathologists look to see which of these slides have cancer cells on them and measure the size of the cancer. They look to see if any of the cancer cells come too close to the edge. This is why each edge was painted with a different coloured ink. If a cancer cell comes close to the edge, then the pathologist will measure exactly how far from the edge it is in millimetres. The specimen shown has been enlarged on a computer screen. You can see that the cancer, which is seen as purple, comes close to the black ink and is measured as being 3 millimetres away from this edge. The pathologist also assesses the grade of the tumour. Cancer cells are given a grade according to how different they are to normal breast cells and how quickly they were growing. There are 3 grades of invasive breast cancer. Grade 1 looks most like normal breast cells and is usually slow growing. Grade 2 looks less like normal cells and is growing faster than Grade 1. Grade 3 looks different to normal breast cells and is more likely to be faster growing. Grade is different to stage of breast cancer. The grade of tumours sometimes changes from the grade on the original core biopsy result, as the specimen removed at your operation is much larger, so this allows for analysis to be performed over a much larger area. The tumour is also tested to see if it is ER positive and HER2 positive, according to how much brown stain is seen in the cells. Some of these tests will have been done on the core biopsy taken from your breast. If you have had lymph nodes removed, they are also sliced into thin slices and placed onto glass slides for analysis under the microscope. The pathologist is looking to see if any cancer cells are present, and if present, the total size of the cancer deposit in each lymph node. Analysing the breast tissue and axillary nodes is a time-consuming process, and the results then need to be discussed at our multidisciplinary team meeting. It therefore takes 2 weeks or more to get the results. We are aware that the time waiting for results is an anxious time, but please be assured that during this time, pathologists are working very carefully and methodically to analyse the specimen in microscopic detail. A multidisciplinary team meeting allows us to discuss your treatment as a team of surgeons, radiologists, radiographers, pathologists and breast nurses, so that we can offer you the best advice and care at your clinic appointment. When you are seen in clinic or have a telephone consultation following your surgery, you will be advised of the results. You will be advised of all the details the pathologist found when analysing the specimen. You may be offered more surgery if the tumour was found to be too close to the edge of the specimen. Usually, this is when the tumour comes within 1 millimetre from the edge and is called a close or an involved margin. The pathologist will be able to tell us which edge the cancer came close to based on the colour of the ink at that site. It is then likely that you would be offered more surgery to re-excise more tissue from the breast. This involves reopening the cavity left from your previous surgery and removing the part which had been lying next to this involved margin. We describe this operation as a re-excision of margins or a cavity shave. Once this further surgery has been done, the tissue is analysed in a similar way under the microscope to see if there are any further cancer cells in this specimen and how close they come to the edge of the specimen. If there are no cancer cells in the shave, or the cancer cells are more than 1 millimetre from the new cut surface, then surgery is considered complete and no further surgery is required. If any cancer cells come too close to the new cut surface, then it may be necessary to again remove some more breast tissue from your breast.